Great. So yes, today I'm going to talk about protocol optimization for high quality and low dose. These are my disclosures, really not relevant for this topic. Objectives of this talk today are to understand practical radiation dose reduction techniques, learn to implement some strategies that reduce radiation dose while maintaining relevant image quality, and demonstrate some approaches to optimize CT parameters and IV contrast infusions for excellent vascular CT image quality at low radiation dose, in large part because I think some of these protocols are the hardest ones for us to get right. So if you were at my talk yesterday, I presented this. I think about radiation dose and risk as a drop in the bucket, where we incrementally add small amounts of risk to this overall bucket of cancer risk for a patient. We talked about how radiation dose is important because the larger the dose, the higher the presumed risk of downstream carcinogenesis. And we talked about the frequency of these drips or the amount of imaging utilization, recurrent imaging utilization, making a difference for a patient in how rapidly we might be accruing risk. So we talked briefly about what we can do. We can work to reduce drip rate, or we can work to reduce drop size. And yesterday I tried to focus mostly on this. What can we do before the scan to reduce drip rate to control utilization with a variety of interventions? Today I want to focus on during the scan, what can we do to reduce drop size, to dose optimize our protocols, to find the sweet spot between the lowest rate exposure that's appropriate for the clinical scenario, while still providing us with a robust and diagnostic quality exam. So I'm going to be stepping through today a number of these different broad categories of tricks we can use to reduce radiation dose without hampering our image quality. The first is really to understand and enable dose reduction tools that are available on your equipment. And we've seen tremendous gains in available tools over the past 10, 15 years as the CT manufacturers really got on board with trying to address this problem of radiation exposure to patients. One of the most long-standing and robust radiation dose reduction tools that we have on all scanner models these days is tube current modulation here. And so what you're seeing is along the z-axis, or from head to toe in the patient, we have in green the relative tube current being adjusted throughout the patient in order to maintain a relatively constant level of image noise, as shown in these red dots here. The way this is done is we have a couple of different flavors of tube current modulation. There's longitudinal tube current modulation, which is best shown in the solid green line here, where we take advantage of the fact that areas such as the lung have very little X-ray stopping power. And so we need much less in the way of X-ray flux to penetrate through this part of the body and to give us the image quality we need. At the end of the day, the image quality that we get depends on how many detectors how many X-rays, hit the detector on the back end. And so we need to adjust the amount of incident X-ray flux on the front end to maintain that. And that's what you see here. So we can get away with very few X-rays through the lungs. We need many more through the shoulders and through the abdomen and pelvis. The other thing we have is in-plane or axial or XY tube current modulation. And that's that with every gantry rotation, we need more X-rays through the thicker parts of the body, like coming laterally through the shoulders, compared to front to back projection through the same area. And so here you can see fluctuations from very high lateral dose to much lower frontal X-ray flux. So that's in-plane modulation. And then you have EKG modulation as well that's relevant for cardiac gated exams also. Here's what happens if you don't use tube current modulation. This is from back in the day, low dose lung cancer screening exam, fixed MAS technique. And you can see that we have much more noise through the shoulders and through the abdomen than we do through the central part of the chest, as you can see in the heart here. this is fine if all we're looking at is the lungs, but it's not great if we want consistent image quality from top to bottom. So how does tube current modulation work? It varies by scanner. This is the Siemens and Philips approach, where basically we have a reference attenuation value that has selected to match a sort of a typical sized patient, whatever that might be. We define a quality reference MAS in the case of Siemens, or an image quality standard in the case of Philips. And that is the MAS that we would use wherever the patient's attenuation matches this reference value. The scanner then adjusts the actual MAS above or below the reference value to better penetrate large areas of the body and to ramp down the X-ray flux in smaller portions of the body that don't need as much X-ray flux. Now, the other approach that's used, which is more commonly used in the GE and the Canon machines, is to basically try to maintain equivalent noise, equal noise throughout the different thicknesses of the patient until we hit a maximum or a minimum MAS that we can either set as a parameter in our protocols, or that we hit the maximum MAS that the X-ray tube is able to produce. What we then adjust, the adjustable parameter, is the noise index in the case of GE, also called the standard deviation in the case of Canon. So this means that high noise index means we're willing to tolerate more noise in our image, which means lower X-ray flux. Or if we set a low noise index, that means we want less noise in our image. We want a smaller standard deviation of the noise if we were to make that measurement. And so that drives our radiation dose higher to maintain that higher level of image quality. So the main point here is that the adjustable parameters are very different from manufacturer to manufacturer. And if you want to make the best use of your technology, you need to have some understanding of what the tools are available and how to modify them. So here's an example of tube current modulation gone wrong. This does not have equivalent image quality from top to bottom. You can see in the liver here, we have much more noise up towards the head and much less noise towards the feet here. What happened here is we did the planning projection radiograph. This is what the scanner uses to determine the X-ray attenuation as a function of Z position. But then the patient moved north. Something happened, they got up, they repositioned, they went about 10 centimeters towards their head, but we did not repeat the planning projection radiograph. And so this is critical. This is what the scanner uses to determine how much X-ray flux to administer. So here, the scanner appropriately gave the right amount of X-ray flux to penetrate the lungs, but now we have the liver and the spleen and the kidneys in its place. So we get a noisier image because we did not appropriately ramp up the X-ray flux for that portion of the body. Here's an example of two patients, different sizes. This is the image quality that you see. The contrast timing is different here, but if you look in the soft tissues, you can see that the noise in the soft tissues is relatively comparable between these two scans. How did we accomplish that? Well, if we look at the CTDI vol, this patient required more than double the X-ray flux as this patient in order to maintain our desired image quality. And this is appropriate variability in radiation exposure in order to maintain image quality. If we look at a larger cohort of patients, here we have patients varying tremendously in size. Here I'm plotting mean water equivalent diameter on the x-axis, CTDI vol on the y-axis. This is purely adult patients, but we see an appropriate 8-fold variation in CTDI between our smallest adults and our largest adults. Again, just because of the physics of the situation, we just need that many more X-rays to penetrate through these very large patients and still end up with enough X-rays hitting the detector to produce the image quality we're after. One of the other tools that we can use to reduce dose to patients is really to reduce the number of passes and duplicate coverage that we use. And there was a while where it was very popular to do a lot of extra phases. You do an abdomen pelvis CT, let's throw in a delayed scan of the kidneys and the bladder, just in case we might find a transitional cell carcinoma. But that added an extra 80% DLP to these scans. The other example that I like is for dissection. What we had been doing many years ago for our standard dissection protocol in the ED was a non-contrast chest for intramural hematoma, followed by a cardiac-gated CTA of the chest, followed by a delayed scan through the chest, abdomen, pelvis. So we have scanned the chest 3 times in this protocol. We switched to a screening protocol for those patients with relatively low likelihood of having dissection, but enough concern that we still needed to rule it out. And we do only a non-gated contrast-enhanced chest CTA, single phase. We get rid of the extra 2 phases in the chest, and we get rid of the abdomen pelvis phase. And this alone, without changing any other imaging parameters, reduces our overall DLP to the patient by almost 80%. Just because we're getting rid of the extra phases and passes. Here's what it looks like. We have this protocol where anyone coming to the ED for an aortic dissection, if they are high risk for dissection, they're hemodynamically unstable, they have a previous dissection and concern for extension, in that category, we do the all-out protocol. That's the non-contrast chest, and we do a single CTA through the entire chest, abdomen, pelvis. But the vast majority of our patients have a low pretest probability for dissection. This is a screening population. We do a single pass CTA chest only, and if there's no dissection, we're done. If dissection is present, we will typically want to extend the scan, through the rest of the vasculature. And that can either be done in real time by prescribing this additional pass to be started right away if a dissection is recognized, or we can bring the patient back and do another scan. We use very little IV contrast for this, and it's perfectly appropriate to re-inject to complete the imaging for this small proportion of patients. What people tend to be most concerned about when I talk about this is the indeterminate cases. So what about intramural hematoma with no dissection flap? Aren't we going to miss that without a non-contrast chest? The answer is no. If we see crescentic high attenuation along the wall of the aorta and we're not convinced based on morphology that that's intramural hematoma, we just wait. Actually, 5 minutes is more than enough for the iodine to clear out of the blood pool in the aorta and to show that intramural hematoma to be a hyperattenuating crescent. The other question that people get concerned about is what about aortic root dissection or pulsation? This is really not much of a concern with current day scanners that are optimized to maximal scan speed, high pitch, high fast gantry rotation. We have very little motion artifact, and what we do see is pretty easy to recognize as artifact. So the main message I have here is that it's okay to bring back an occasional patient. If we think about this as what's best for the patient rather than what's most convenient for us, I would rather bring back one patient in 500 than scan the other 499 with all of these extra phases that they really don't need. All right, let's move on to the next strategy, which is to reduce MAS when possible. And the key thing to recognize here is that the radiation dose requirements depend on the diagnostic task that we're after. So if we have high contrast structures, we can tolerate a lot more image noise without hampering our ability to make a diagnosis. Classic examples, lung cancer screening. Find that nodule against this largely air-filled background of lung. CT angiography, if we can get really great contrast enhancement in the vessels, we can tolerate more noise in our images. Ureter CT, if our only goal is to find kidney stones, that's a bright structure against a soft tissue background. We can do that task with drastically reduced radiation dose. Caveat being that in the ED, for example, we're looking for other things than just ureteral stones. So we try not to ramp down the dose as much as we would if the only task was for ureter stone detection. One of the tricks here is to reduce MAS incrementally to find the comfort zone of image quality for the diagnostic task. Back in the day when everybody had radiation doses and much higher than needed, and image quality much better than truly needed, it was an interesting discussion to say, hey guys, should we add more noise to these images? No one really wanted to do that. And so my experience was that the best approach was to not ask anyone's permission, to start making incremental decreases in MAS, 20% steps, and nobody notices. And you make another and nobody notices. And finally, one day someone says, hey, these images look a little bit noisy. What's that guy Sodickson doing to my image quality? And you hear about it, and that's fine. You go up one more click and you've found your sweet spot. But in many cases, practices are operating at much higher MAS than they truly need for diagnostic comfort. The next strategy to talk about is optimizing IV contrast infusion. I mentioned that if we can optimize the vascular enhancement in our scans, that increases the contrast to noise ratio. We can therefore tolerate more noise, crank down to lower dose technique. This also reduces the need to repeat non-diagnostic scans on the basis of IV contrast infusion. Repeated scans add radiation dose. So this is a great way to improve our practices. Here's an example in PECT. Many years ago, we were giving a lot of contrast, 125 ml at a low flow rate, 3 ml per second. And our PECTs honestly were not all that great. We weren't thrilled with them. We tried a change. We reduced the amount of IV contrast that we used, but we increased the flow rate, added a saline flush, and we found fairly equivalent Hounsfield unit values in the main pulmonary artery in these patients. We went a step further, 75 ml at 5 ml per second with a saline flush, and saw a pretty substantial improvement in the contrast enhancement in the main pulmonary artery. Now, to do that, you can see from the simulation, we need to match the timing of the bolus very tightly to the peak of the enhancement curve. And so that really prompted us to make new requirements for the IVs that we use for this study. We prefer at least an 18 gauge IV. We prefer it in the antecubital vein. We can accept it in the forearm. We do not inject hand IVs because 5 ml a second is just not a good idea there. This required negotiation with emergency medicine. We basically told them, you want a PECT, you want it to be good, this is the price of a good study. We also had to train our technologists that the power injector had to be started from the scanner console, not from the room. Our techs had been very used to feeling the IV as the contrast goes in to try to detect infiltration early. But from the time you start that injection to the time it hits the pulmonary artery, there's maybe 5 seconds typically, and very few techs can run that fast from that room to the console room. And so the IV needs to be checked first. If there's comfort that it's flowing well from saline injection, start the injector from the console room. The next thing that we use for our vascular studies is to reduce KVP. And so here's a homemade phantom with a bag of saline in the middle and bags of saline containing contrast on either side. And if you just look at the Hounsfield unit values compared to 120 kV, you can see that for obviously the same concentration of iodine in that bag, we're getting 27% higher Hounsfield units at 100 kV, 74% higher at 80 kV. At the same time, if we don't change our MAS or our technique settings, this reduces radiation dose with CTDI vol decreasing 42% at 100 kV, 72% at 80 kV. And so this looks like a win-win. We've got better contrast enhancement, lower radiation dose. The main caveat is this doesn't work for very large patients. So for a while, we tried 80 kV in adult patients, and even though you got blazing IV contrast enhancement, there was so much noise in those images that they were very challenging to read. And so for adult patients, we have settled on 100 kV as our real sweet spot. This is the protocol that we developed for larger patients over 175 pounds, scan at 120 kV, 75 ml of contrast at 5 ml per second with a saline flush. For patients less than this arbitrarily selected 175 pounds, we scanned them at 100 kV, 50 ml per second at 4 ml per second. And this was a great protocol, preserved diagnostic quality while reducing IV contrast volume by a third, down to from 75 to 50, and reducing radiation exposure by a third as well. And here is that data. The red dots here are the smaller patients scanned with this 100 kV protocol, and you can see the 33% reduction in radiation dose despite the decrease in IV contrast volume with maintained image quality. Here's an example, 2 patients. These are considered to be the same size on the scanner according to the tube current modulation calculations. You can see that image quality in both cases is excellent. The IV contrast enhancement is good. We have a little motion artifact on this old scanner here. You can see there's a little bit more noise in the soft tissues in this 100 kV scan, but that's okay. The main purpose of the scan is vascular enhancement for pulmonary embolus identification. One of the things that remains after we solve that is the occasional non-diagnostic scan. And so I just wanted to mention for the radiologists here, we need to be able to recognize what goes wrong so that we can fix it. And so this is a perfect example of a poor pulmonary embolus CT, which is confusing. We've got contrast still coming down the SVC. We have contrast in the aorta, and the vascular structure in between is washed out. And this is classic contrast interruption from Valsalva effect, where the patient takes in a deep breath, which makes negative intrathoracic pressure. They bear down in the abdomen, positive pressure below. That creates a pressure gradient that forces contrast, unenhanced contrast, up the IVC here. It slams into the contrast column from the SVC, and we get all this mixing in the right atrium that then passes through and washes out the pulmonary outflow tract and the pulmonary arteries. So how do we solve this? When this occurs, we repeat the scan exactly as we did before, but we now do the scan in expiration. Because with the expiration, the diaphragm is up, we have higher pressure here. It's impossible to Valsalva when your breath is out, and that changes those contrast dynamics, and we get a beautiful scan. Since we're only giving 50 ml of contrast, we really don't feel bad about repeating that. And since our radiation doses are low, we also feel okay when needed about doing what's appropriate to get the clinical question answered. Here's another one. This is another example, poor enhancement in the pulmonary artery. We have contrast in the aorta, but in this case, we have nothing in the SVC. And this is a different scenario where if we look at the monitoring scan, this ROI has fallen off the main PA, which is right here, and into the aorta. And so we timed it very nicely as an aorta study, not as a PE study. And this just needs a replacement of that monitoring scan ROI, and we get a beautiful scan with our repeat. All right, let's move on. Using noise-reducing reconstruction techniques. The first one is very low tech. It's fine to acquire thin images for reformats and problem solving, but it is best to read thicker. So keep in mind that 4 millimeter images have half as much noise as 1 millimeter images because they've got 4 times as many X-rays contributing to their creation. Noise goes as the square root of the number of photons. So my point is, if you've got too much noise in your images on the thins that we typically do for a PECT, thicken them up a little bit. You can really knock the noise down significantly. And the other corollary to this is please do not try to make 1 millimeter images with the level of noise that you're used to in your thick images, because that is going to drastically drive the radiation dose up. The other tools we can use are iterative reconstruction or other noise reducing post-processing tools. And here's an example in the abdomen coronal image through the kidney, and we have an appendicitis up here tickling the lower portion of the kidney. These are progressively increasing strengths of the iterative reconstruction algorithm, and we've got to decide what value we want to use. The higher we go, the more noise reduction. On the other hand, the higher we go, sometimes the complaint is that these images look artificial or plasticky or smoothed. And so in many cases, we just pick a middle of the road value, strength of 3 on this particular scanner platform is what we had honed in on. But when we turned that on, you can see that if we look now at a plot of our CTDI over time, we had just dialed in a 33%, radiation dose reduction with our reference MAS selections. And you can see that step function decrease in the CTDI we're delivering to our patients as a result. Motion artifacts, we very much like our high-pitch dual source scanners. These sorts of motion artifacts on PECTs are very frustrating. They make it very hard to assess the vessels in the lower lobes. It can raise concerns about dissection, artificially simulating dissection in the aorta, and we often see some motion along the left ventricular free wall. By using a high-pitch dual source mode, we can scan the patient with a pitch of 3. The whole chest typically takes less than a second, and we can really reduce the measurable duplication of anatomy like this between single source and high pitch mode in the diaphragm, at the ascending aorta, and along the left ventricular free wall. One of the benefits of this high pitch mode, as I mentioned, is to decrease pulsation or motion artifact. But the other thing that's been interesting when we added that feature is that scanning the patient faster means we have less S in order to create the MAS we need. That means we need higher MA to accomplish the desired MAS that we need to reach the image quality we want. So what we found is that for larger patients, we did need to train our techs to just reduce the pitch in order to achieve the desired MAS without hitting the maximum MA of the tube. On this scanner, the yellow represents areas of the body where we have hit maximum MA tube output limits. And so we're going to see more noise through these portions of the scan compared to this portion where tube current modulation is basically allowed to do its thing. But that's okay, because for this application, I would accept this tube current modulation scheme, even knowing that we're maxing out and we're getting more noise through the shoulders and the diaphragm. And so we trained our techs to basically keep most of the lungs in the green by knocking down the pitch a little bit. And that allows us to keep doing these scans, actually even in some rather large patients at 100 kV. This trick gave us some additional incremental dose reduction compared to our regular approaches. First, because the narrower bow tie used with the high pitch mode gives us about a 20% radiation dose reduction. But also, this trick with the techs allows us to truncate the maximum MA at the top and bottom of the scan, and that gives us roughly another 20% dose reduction. So this has become our routine protocol for PE or dissection CTA. Here's what our radiation dose has looked like over time. This is plotting CTDI box plots by month. This was from 2012 to 2015. Before all of this was the switch to 100 kV for the vast majority of our adult patient scans. That gave us that 33% dose reduction that I mentioned earlier. Here is where we added iterative reconstruction at that intermediate strength, and we dialed in a 33% dose reduction in our reference MAS values. And here is where we added high-pitch dual source mode, giving us that additional 40% radiation dose reduction. And so each of these steps is a relatively modest radiation dose reduction, but if you take them all together, we end up with a roughly 75% radiation dose reduction from where we started back in 2010 or so. The median CTDI vol for these scans is down to about 3.75. The median DLP 130 milligray centimeter. And if you use the usual conversion K factor, that means that on average in this patient population, these scans are at less than 2 millisieverts, which is really makes us feel good about these scans and also makes us less concerned about repeating these scans in those now very few cases in which we have a poor contrast bolus, for example. So in conclusion, really, the main point I think here is that we have a lot of tools available on our modern day scanners that allow us to create high quality images at low radiation dose. I really encourage our radiologists and of course our medical physicists and technologists to take the time to learn your technology. One of the best things that I did when I was in residency was sit down at the scanner and ask the techs to teach me how to run it. Because then you get a real sense of what the different parameters are and what the trade-offs are. I think it's important to work together to optimize protocols. This is a team effort with radiologists, technologists, physicists, and the manufacturers. I encourage everyone not to overdo it, because if you go so far that you have a non-diagnostic scan, you've provided no benefit to the patient, and you're setting yourself up for repeating a scan, which is, of course, doubling up on the dose. Results in general are best by combining synergistic approaches, as I showed you, each of them in moderation. There's no one silver bullet that you can just turn on to have a very high quality low dose scan. It's best to use the different tools in combination in this way. So I'll stop there. I would be quite happy to take any questions. Let me pull up the QA. And feel free to add any additional questions if you'd like. So should I start on those questions then?
Yeah, go for it.
All right. So the first one is, do you see a difference with errors when technologists use auto scan? I trigger the scan manually by watching visually, not allowing the scanner to decide when to trigger. This would allow for a decrease in errors if the patient has shifted or moved in the example you have shown. Yes, Lorenzo, you have described one of my favorite tricks when we're having a difficult scan. We do use the, what Lorenzo is referring to is on the PECTs, where we were talking about placing the region of interest over the main pulmonary artery to trigger the scan when we have contrast reaching the right place. That is a great trick. It's a great tool. But it doesn't always work if the patient has moved and the region of interest falls off the vessel of interest. And so one of my favorite tricks is to put that region of interest outside the patient, in the air outside the patient, and that forces the tech to watch the scan. And basically at the first whiff of contrast that's visible in any of the pulmonary arteries, the scan gets triggered. So I think that's an outstanding technique that I encourage. And it really keeps the techs engaged with that individual patient's scan. Excuse me. The next question I see from Donna: when employed as a senior radiologic technologist at UTMB Galveston, my coworkers and I image numerous children at Shriners Burn Hospital, as well as the acute adult burn unit. Question is, if you have a child or adult with severe second and or third degree burns, how quickly can a CT scan be performed with low dose, minimizing exposure for a quality exam? So how quickly, I think, depends, on a bit on the scanner in terms of the actual scan acquisition itself. I think, these days the scanner technology we have is so fast that most of the time spent in the CT room, of course, is in patient preparation, getting them on and off the scanner, getting them hooked up to IV contrast as needed. So if you're talking about patients that are moving or in pain, certainly the high pitch mode that I talked about can be very helpful and has been studied extensively in pediatric patients. So, for a typical 30 centimeter length chest CT, I can tell you that our usual scan time with pitch of 3 is 0.9 seconds. This gets a little bit to Jan's question, which is next, would you recommend increasing pitch above 1 and decreasing time per rotation to make scan faster for pediatric heads to reduce motion? So in general, I think we underutilize the speed of our scanners. For keeping on the PECT topic for a bit, not all of our scanners are dual source. We can still do a very fast scan by increasing pitch as much as possible, which is typically 1.5 on most single source scanners, and going to the maximum gantry rotation that scanner can do to reduce the scan duration. The head is, yes, you can use some of those tricks, but you have to be a little bit careful there because some of the scanners don't want a very fast gantry rotation. I know the Siemens scanner is better than the others, and in this example for the head, they do this flying focal spot, where they move the focal spot back and forth to increase the z-axis resolution, and that does not work at the very high gantry rotations. So there are a few caveats like that that you need to engage your applications people for to figure out really what the fastest scan modes are that are appropriate for your scanner. The next question I see is, do you ever switch to 80 kV in adults? If so, what size cutoff, and what about pediatric patients? The answer there is we tried 80 kV in adults and very quickly moved away from it. I think you could certainly find a few very small adult patients where you could use 80 kV, but we didn't really see a lot of value to that, and very quickly settled in on 100 kV as our sweet spot because it's very robust, and we don't need to think too hard about when to use it. Many of the scanner manufacturers now have these automated kV selection tools where it will figure out which kV is best for the patient based on the size from the planning projection radiographs and the goals of the scan, vascular versus non-contrast, for example. But I'll tell you that we actually configured on our scanners to only allow 100 or 120 kV, at least for our vascular scans. 140 kV we don't like for our vasculature because you throw away your Hounsfield units. Yes, you get better penetration of the larger patients, but at the expense of losing your enhancement from iodine, which is the point of the scan. So for us, we always limited that to either 100 or 120. All right. Next question, would scanning PE studies with expiration breath holds avoid rescanning, especially in pregnant patients? I love this question, Maria, and yes, it would. And so we toyed with this for a long time. Should we just do all of our PECTs in expiration? And it's great for the vasculature. The problem is the lungs don't look so great in expiration. And so we end up seeing a lot of ground glass opacities throughout the lung, and there's a tendency to overcall things like pulmonary edema or atypical pneumonia, like viral pneumonias, from all of that ground glass. And so we stayed with the inspiratory scan. We see the lungs very nicely to clear the lung parenchyma. And if we have those rare issues with vascular enhancement, we can repeat in expiration. I should add that when we went to the high-pitch dual source mode, we moved away from that. And we don't do it in expiration, we just do them free breathing. So wherever the patient happens to be in their cardiac cycle when we do that 0.9 second scan is when we do it. So we don't make an effort to time to the breath hold. So occasionally we do see patients who happen to be in expiration during that scan, and we have to deal with a little bit more of that variability in the ground glass appearance of the lungs. But I do think it's a nice approach in some patients. Pregnant patients can be prone to pulmonary edema. So I have a little bit of caution there and never actually pulled the trigger on making that change. The next question is, do you use dual energy for your PE scans? This is another great question. Historically, we have not. because on a dual source scanner, we have a choice between dual source mode and dual energy mode. And as I pointed out, we love the high-pitch motion reduction features of the dual source mode so much that we haven't wanted to lengthen scan duration in order to operate those two tubes at different kVp to create a dual energy scan. That said, on the the force scanner, you can do a pretty fast dual energy scan. I think it's about 1.5 seconds through the chest, which is enough to reduce almost all motion artifact. And on the new photon counting scanner that we just installed, we have simultaneous high pitch dual source mode with the spectral information that's now derived from the photon counting detector without need to run the two tubes at different energies. All right, so then the next question is that 18 to 20 gauge on the right or left AC is ideal for CTA, but sometimes I have a hard poke patient, can't get the IV on the AC, so we do from the wrist and it works as long as we have 18 to 20 gauge. I agree entirely with that. I think I mentioned forearm. I should have been a little bit more liberal. We will accept a wrist IV. We just try to avoid the hand because of the higher risk of contrast infiltration. Next question. If you think a PE study might be suboptimal, can an ROI be placed in the pulmonary trunk and measure the Hounsfield number? Is there a minimum Hounsfield number you like to see? Yes. Typically I would consider 250 Hounsfield units in the main pulmonary artery an adequate study. I'm much happier if we have 300 or 350 Hounsfield units in the main pulmonary artery. And I think that's eminently achievable with some of the protocol optimizations that I talked about. But in terms of deciding which ones do we need to repeat, 250, 200 Hounsfield units is probably the right time to think about that. The other thing, though, to consider there is that you don't always have uniform enhancement throughout, and often in the case of contrast interruption from Valsalva, you'll see that the central pulmonary arteries are washed out, but actually the periphery might have better enhancement. And 200, even a little bit less in the central pulmonary arteries is fine for ruling out a large central saddle embolus or lobar pulmonary embolus. If you have higher enhancement in the periphery, you're probably okay and might not need to repeat the scan. But we've basically asked our techs to give us a call whenever they are not sure that we have a scan so that we can decide our level of comfort with the study and whether or not we want to re-inject and repeat. And then we have another question on CTA study. We use 95 to 100 ml of contrast at 4 per second. Should I reduce to 70 at 4 or 5 per second? Personally, we have been quite happy with our protocols at either 75 or 50 ml. It depends on the kV that you're using. And so for us, the sweet spot, as I mentioned, has been 100 kV. For that, for either a PE or an aorta study, 50 ml at 4 per second works beautifully. You have as much contrast as you need. And the other thing that I like about just using 50 ml is then, again, in those rare cases where we need to problem solve and re-inject, we really don't give a second thought from a contrast perspective at doing what we need to get the answer. So I think I got all of them.
Thank you. That was an excellent talk and generated so many great questions. If I could ask one last question, you've given so many feasible, accessible tips on how to modify KV and contrast, and we love that algorithm for how to reduce phase in, I think it was aortic dissection. But in our registry data, we're still seeing a huge number of sites sticking to multi-phase. We see no change in KV. We actually have a paper coming out very soon on that. And just in general, sites are not optimizing, not using known best practices. So any last thoughts on how we can standardize these practices that you've recommended?
Yeah, that's a great point. And I think what it really comes down to in most cases is who owns the protocols. Who is driving these changes towards best practices. Um, and my opinion is that you need radiologists involved in this process to sort of champion some of these changes. You need a team. You need a really knowledgeable lead tech or more than one who understands the technology on the scanner and can work collaboratively with the radiologist to make some of these changes. The tools are there. So, I think it really comes down to needing some ownership at each of these locations for who's actually going to make the changes. A lot of places have a director of CT, medical director of CT, a technical director of CT on the technologist side. And I think those folks really need to work together. But, certainly the decision about multi-phase scanning, that's a radiologist decision at the end of the day. And so you need people to be comfortable with reverting to a single phase. I will tell you that in the ER, there are very few scans that we do multi-phase, a vanishingly small number. CT angiography in the abdomen for GI bleeding, where we want a more delayed phase to better see contrast extravasation in addition to the arterial phase. That's one example. But that's it in the abdomen for us. And so I think, it's hard to change physician practice, but radiologist sort of leadership is needed for that. Thanks for the question.